This is the last part, and we're just going to go over something which is very important when people are having chemotherapy or when they're having radiation therapy for cancer, and that is the use of anti-emetics, drugs that are designed to prevent nausea and vomiting. When it comes to cancer chemotherapy, one of the very common side effects, and one which really distresses people and puts people off chemotherapy, is the nausea and vomiting that comes along with it. How likely you are to get nausea induced by your chemotherapy depends on the agents that are being used. Some of them have a very high liability for producing nausea and vomiting, some of them much lower. But if, as is quite likely, the cancer chemotherapy includes a combination of agents which makes the cancer killing much more effective, unfortunately, you get the additive effect of the individual agents and their liability to produce vomiting. So if you happen to be being treated with 3 agents, all of which have a high liability to produce nausea and vomiting, then you're going to have a horrendous time, unless you have adequate control of your nausea and vomiting with these lifesavers, which are the anti-emetics. Now, emesis, or nausea and vomiting, will often start within about 4 hours of treatment. So if you go in for a round of chemotherapy, about 4 hours later, you'll start to feel nauseous and start to vomit. It peaks about at the 10-hour mark, and then it will subside over the subsequent 24 hours. So it's around for quite a long time. And a number of people will report that they don't really feel right for quite a long time after that. Now, vomiting, as we all probably know, is highly aversive. It's meant to be because it's a survival mechanism. If something causes you to vomit, if you expose yourself to something, eat something, put something in your mouth, which causes vomiting quite quickly after the event, it will be strongly aversive the next time you're exposed to it. And that is meant to happen because it's supposed to initiate powerful learning when we're young and prevent us from eating things that are poisonous to us. Of course, if you use drugs which activate that same nausea and vomiting, you will also activate that aversive response. In other words, often people will not want to continue with their chemotherapy, even though it may well save their lives, because of the aversion to the nausea and vomiting that they know will happen. And it can be so serious that the treatment can't continue, so treatment is delayed. And with cancer, that's the last thing you want to have to do. So it's a really serious issue. And while we're talking about therapy-induced vomiting, we must include radiotherapy-induced vomiting, because radiotherapy is also a treatment for a number of cancers. And although we haven't talked about it because this is a pharmacology course, it does also induce vomiting very commonly. Now, just like the chemotherapy, it doesn't always induce vomiting, but there are different types of radiotherapy that are more likely to produce vomiting than others. Broadly, if you have brain irradiation or upper abdominal or total body irradiation, you are more likely to suffer from nausea and vomiting as a result. It means that the higher the doses of radiation, either in a single session or a cumulative dose over a number of sessions, will produce radiotherapy-induced vomiting. If you have radiation over a larger area of the body, then you're more likely to experience it. It starts usually a little bit more quickly than with chemotherapy. It may start within 1 to 2 hours of the radiotherapy treatment, and it will subside over the following 10 hours. And again, it has a powerfully aversive effect, and it can lead to refusal of treatment or to delay of treatment, because the vomiting may be so severe that it really isn't feasible to continue giving the person the therapy until they've recovered. So why do these things produce vomiting? Well, here's a diagram which is showing you the inputs to an area in the brainstem known as the vomiting center, and an area also in the brainstem to the side of the vomiting center called the chemoreceptor trigger zone. These two parts of the brainstem are key in the production of nausea and vomiting, and you can see in all these boxes the various inputs to the vomiting center that can trigger vomiting. So there are inputs obviously from the gastrointestinal tract itself in the form of stretch receptors, pressure receptors, in the form of chemoreceptor stimulation, and also serotonin receptors. 5-HT and serotonin are the same transmitter. 5-HT is the English name. The serotonin 3 receptor is known to be involved in the production of vomiting responses and can feed into the vomiting center as well. And there are also receptors in the heart which can do the same thing. The central nervous system, of course, particularly the cerebral cortex, can feed into the vomiting center. So your conditioned responses will be generated from the higher levels of the central nervous system. That is not surprising. We also know that there's inputs to the vomiting center from the vestibular system, which is also not surprising. These are your balance canals in the inner ear. If you wobble your head about too much, if you go on a boat, for example, on choppy seas, you're stimulating your vestibular system quite strongly, and that can cause sickness by feeding into the vomiting center. And then there are inputs to the chemoreceptor trigger zone, which will in turn elicit vomiting, and these are produced by toxins that are detected either in the blood, in the cerebrospinal fluid, or in the gastrointestinal tract. So there are chemoreceptors all around the place that are tasting the composition of what you've been exposed to, of what's got into the body, and if they detect toxins, then they will trigger vomiting as a protective mechanism. So there's been a lot of work done on pharmacology of this vomiting response, and you can see listed here in this diagram, which is why I've put it in, the receptors that have been identified as being involved in these various ways of triggering vomiting. And if you look at these two areas, the chemoreceptor trigger zone and the vomiting center itself, there have been a number of receptors identified in those locations that are known to be involved in the induction of vomiting. So, for example, we've got dopamine 2 receptors here. We've got 5-HT, serotonin 3 receptors here in the chemoreceptor trigger zone. We've also got muscarinic receptors of the M1 type. And this one here, NK1 receptor, NK standing for neurokinin. So an array of receptors have been identified in the chemoreceptor trigger zone. And in the vomiting center, we've got the H1 receptor, that's a histamine receptor, the M1 receptor, a muscarinic receptor again, the neurokinin 1 receptor, the 5-HT3 receptor, and the dopamine 2 receptor again. So some receptors in common between these two areas that are known to be involved in vomiting. Now, why are we interested in those receptors? Well, because as pharmacologists, if we know what receptors are involved, then we can be on the hunt immediately to find blockers of those receptors to try and interrupt the vomiting response that is produced by chemotherapy and radiotherapy. Now, I'm just going to tell you about two major types of antiemetics. There are more, but these are the two that are currently most commonly used. And the first group are dopamine 2 antagonists. Names of a couple of those agents most commonly used of this group are metoclopramide and domperidone. Now you can see why they would be useful. There are the dopamine receptors both in the chemoreceptor trigger zone and in the vomiting center itself. If you block those receptors, then potentially you can block the triggering of the vomiting, and that seems to be quite effective. Metoclopramide, although we're talking about controlling vomiting due to chemotherapy and radiotherapy, there is also, as you probably know, often vomiting in the early stages of pregnancy, and some women suffer really terribly from that kind of vomiting. The unfortunate thing for pregnant women is that a lot of these antiemetics potentially can harm the baby in some way. Metoclopramide is probably the only one that is relatively safe to use in pregnancy. So you'll find metoclopramide also being used to control serious morning sickness. If you don't have to use a drug in a pregnant woman, then you wouldn't. But if somebody is having really serious morning sickness, then metoclopramide would be the agent that would be used. So dopamine 2 antagonist, metoclopramide and domperidone, good antiemetics. And the other group are the serotonin or the 5-HT3 receptor antagonists. And again, we can see if we look why we would expect them to be effective. There are 5-HT3 receptors in the chemoreceptor trigger zone, in the vomiting center, and also in the gut itself. So 3 points potentially at which blocking those receptors could interrupt the emesis. So look at the names: ondansetron, lassetron, granisetron, the cetron ending. If you learn that, you will know that these are antiemetics, belong to the 5-HT3 receptor antagonist class, and if you see new ones with that ending, you'll know what they are. So let's just run through some general principles about using these antiemetics to control vomiting during treatment for cancer. First of all, as we've just seen, the two major groups that are used for this purpose are the dopamine 2 antagonists and the serotonin 3 antagonists. But what has been discovered, and we're not sure why this should be the case, is that when those drugs are combined with corticosteroids, for example dexamethasone, and you've covered the corticosteroids before, that they're more effective. You get better control of emesis, better control of nausea. And as I say, it's not really understood why this should be, but since it happens, then the recommendation is combine either your D2 antagonists or your 5-HT3 antagonists with a corticosteroid like dexamethasone, and you'll get a better effect. So why wouldn't you do it? And the other really, really important piece of advice, and we have medical radiation students taking this course, and some of those will be radiotherapy students. And there's quite a lot of talk in the literature among medical radiation practitioners that it's really vital to properly control emesis for all of the reasons that we've discussed. If you control emesis effectively from the outset, then there's no reason why a person should ever suffer the vomiting in the first place, and therefore they won't get the aversive behavior, they won't get that conditioned response to the treatments, and it will just be much better for them. They're much more likely to complete their treatments. A real key part of achieving that is first to get the dosing right. So use your best combinations and dose enough. Sometimes the doses have to be quite high, and you must start it prior to chemo or radiotherapy, the day before, because these antiemetics are not good at stopping vomiting once it's started. They're good at blocking it from getting started in the first place, but not interrupting it once it's started. Ensuring that people do not suffer these horrible side effects when they're having therapy, you must ensure that you dose it adequately and you dose it far enough ahead of the event for it to really work for the person. So this is really a bit of a repeat, but just to emphasize, you must administer antiemetic therapy prior to the chemo or the radiotherapy. Combinations of antiemetics work well, and your dosing must be high enough. It shouldn't be mean with the drugs, because if you can properly control it, then you won't get a lot of the problems that come along with the conditioned responses. And often people, if they have suffered chemotherapy or radiotherapy induced vomiting several times, their response to it becomes conditioned. So, for example, they will start to suffer anticipatory vomiting. When they know they're due for another cycle of either radiation or chemo, they'll start to vomit beforehand because they know they're going to receive that same emetic compound, and their response starts ahead of them actually receiving it. In addition to that, a proportion of patients will suffer conditioned vomiting when they see people or places that they associate with their treatment. So some chemotherapy nurses, for example, have to get used to patients or ex-patients will vomit when they see that particular individual because they associate that individual closely with their chemotherapy treatment. And once you do that, then the conditioning is, okay, here's something that my brain associates with me throwing up, and that triggers you throwing up. So conditioned vomiting is another problem if you do not control the vomiting in the first place. It's win-win if you get on top of that vomiting. So those of you who are going to be looking after people having radiation, mark that well. Make sure they've had their antiemetic treatment before you take them in and irradiate them.